Dr. Laiba Asif, you just come and give your presentation, and small, round and out of place.
Assalamu alaikum, respected judges and dear audience. I am Dr. Laiba Asif, a second-year resident at Mughal Hospital, and today I will be presenting small, round and out of place, managing a case of bilateral microspherophakia. So the story begins with a female who comes to you, a 20-year-old female who's enthusiastic, hopeful, and she wants to get rid of her glasses. So we take a basic history. There was unremarkable systemic history. We move on and performed a basic refraction. So the refraction was that patient's best corrected visual acuity was 612 and 69, OD and OS, with minus 17.50 diopter sphere, both eyes. So we moved on, we counseled the patient regarding the high refractive error and called her for a detailed exam. So, lo and behold, what was seeming like a case of high refractive error, we see a case of bilateral microspherophakia with subluxation. The rest of the exam of the patient was unremarkable. Her IOP was in normal limits. There were no signs of glaucomatous damage and otherwise. So we moved on, and this was an unusual way to visualize the microspherophakic lens. Here you can see the increased anterior-posterior diameter of the lens. And we used this, we took this picture using the Galilei topographer. Patient was concerned about the complexity of the case and the near edge and her desire to remove the glasses. So we moved on, performed the biometry, the target IOL power was selected, and now the most important part, the surgical approach for this and the long-term stability of the back complex is very important. So we select an appropriate IOL, some mechanism for suture fixation, appropriate suture material, role of anterior vitrectomy, and be ready for the intraoperative variation of the plan. So while discussing the subluxations, we need to understand that there is minimal to mild subluxation, moderate subluxation as in this case, or severe subluxation. The origin of the subluxation itself, if it's congenital, acquired, progressive or static. We need to understand that if a subluxation is progressive, we must fixate. Otherwise, the back complex with the CTR will land on the retina. Moving on to the severity and the density itself. Now there are various options. If there is soft lens, then endocapsular aspiration is preferred. Thus, this will prevent the disruption of the anterior hyaloid face, and this will minimize the future risks for retinal detachment. So moving on, this was the surgery. This was performed by Dr. Mazhry. So moving on, the fixation sites for mock conjunctival peritomy was done, gentle cauterization, followed by marking of the fixation site and tunnel formation. So the rexis was very technical in this case. We initiated the rexis. Here you can see it is initiated with the help of vibrata forceps and completed. The rexis was completed and then followed by the gentle multi-quadrantic hydrodissection. Next, moving on, the CTR ring was in place. Here you can see the CTR ring has been injected inside the capsular bag. Now stop here and see. We can see that the bag complex looks very stable and we can inject the IOL and stop the case right there. But this was not the case. Our professor decided to move on with the fixation of this IOL. This IOL was fixated with the help of sutures, as we can see here. The IOL was, the haptics were externalized first, then the suture was entered from the fixation site here. Here you can see the needle is entering the fixation site. This needle will be retrieved here, at this site, where the haptic is already lying outside. You can see here. Once the suture has been externalized over here, the suture is tied to the point of maximum convexity of the haptic. The same procedure is performed on the opposite side. The point to note here, when the needle is being introduced from the fixation side posteriorly, we induce a small hole in the posterior capsule. Here you can see the same side, the same procedure is being performed from the other side as well. The needle is here coming out of the fixation side. The suture passed here. Now this haptic, both haptics will be internalized and the suture will be pulled to finally fix the haptic in its place. So you can note that no anterior vitrectomy was performed in this case. The endocapsular aspiration of the soft lens was performed, followed by fixation of the haptic, fixation of the IOL along with the bag, followed by the case closure. So this was the post-op day 1 picture of the patient. The similar procedure was performed in the other eye as well. So conclusion, implanting CTR in the bag ensures long-term integrity, shape of the bag and centration of the IOL. With minimum disruption of the anterior hyaloid face and vitreous, this will minimize the risk of future retinal detachment, especially in a young patient. So this was a novel approach that we thought should be discussed here. Thank you.
Thank you.
Any questions?
Question is that when you are piercing the capsule with which kind of needle it was used?
So this was 27.
27 age, and did you Dr. Islamabad Mazhry can answer this question. Did you hold the capsule to ensure that it will perforate the capsule? Because when you are pushing this needle, it can damage and can increase the tear size actually in the capsule.
The bag is well inflated, one thing, and second, I use visco cannula. They meet each other at capsule.
Okay.
So that it doesn't go astray.
Counter force from the opposite side
Yes,
to the cannula,
with
and
the
then you hold this. Okay, fine.
Yes.
Any other question?
Minus 9.5 and minus 12.5, right and left.
The interesting thing in this case was that it was detected from screening room.
And what was the outcome, effective outcome?
The patient is studying in Australia with 6.9 VN. And
Autoref reading is
autoref reading is the spherical equivalent is -1.
-1. That's great.
Yes.
Thank you very much.
So my question is that what is the criteria where you decide that you do not put an anterior chamber ACI instead of a scleral fixation?
Sir,
And what are the drawbacks of both?
Sir, the anterior chamber IOLs, especially in those patients who have narrow angles, crowded anterior chamber, in these patients the anterior chamber IOLs may not function very well, leading to the corneal endothelial decompensation as well. Coming on to the posterior chamber IOLs, the timeline to learn this procedure is very long. One of the factors that it's underperformed may be the initial periods of the residency or so. So the anterior chamber IOLs may be an option, but not in the crowded angles and the crowded anterior chambers. So we prefer the posterior chamber IOL as it closely matches the position of the natural crystalline lens in the posterior chamber of the anterior segment.
Thank you very much.
So what are its drawbacks? I was trying to compare both the drawbacks.
So the drawbacks, the studies suggest that the long-term visual acuity of the both may be the same, but the drawbacks of the anterior chamber IOL are furthermore the corneal decompensation, uveitis, glaucoma, hyphema syndromes. Thank you.